Hi, everyone. Welcome back to Clinician's Brief, the podcast, where we bring you the conversations behind our clinical content. I'm the host of this program, Dr. Alyssa Watson, and today I am so excited to be joined by not one, but two outstanding guests, Dr. Jason Bleedorn and Dr. Bryce Talsma. Dr. Bleedorn is an associate professor at Colorado State University, and that is where Dr. Talsma is a third-year small animal sports medicine and rehabilitation resident. They're here today to share their insights on what they consider to be the top 5 osteoarthritis treatment options for geriatric dogs. And spoiler alert, only 2 of the things that we're going to talk about are medications and supplements. So I'm super excited to have this conversation. Obviously, in general practice, osteoarthritis management is something that I deal with on a day-to-day basis. I'm so glad that both of you could carve a little time out of your schedule to be here with us. And before we jump into this discussion, I would like to give you each the opportunity to just give us a quick little introduction, a little bit about yourself and how you ended up at Colorado State.
Cool. Dr. Bleedorn, you want to start?
Ladies first.
Oh, perfect. Okay. So I'm originally from Michigan. I did my vet school at the University of Florida, kind of hoping to go down the aquatics marine health track. But while I was there, kind of realized, maybe the aquarium life wasn't for me, and really fell in love with some of this rehabilitation of injured wildlife while I was down there. And kind of made that switch over to the small animal side and spent more time with the University of Florida's sports medicine department, exploring how multimodal pain management really improved the quality of life of small animals and how much owners valued having their dog be comfortable in its geriatric years. And so that's when I decided to pursue a small animal sports medicine and rehab residency, and followed one of the faculty clinicians from Florida out here to CSU, where I completed my internship and am now just about to finish my residency.
That's great.
Stay on for a year with us, right?
Yeah, and planning to stay on as faculty and hopefully get to continue to educate and inspire people that this is the best field out there.
Awesome. All right. How about you, Dr. Bleedorn?
Great. Jason Bleedorn. I'm from the Midwest, grew up in Chicago suburbs, did my DVM at University of Illinois, did my internship in surgery training, University of Wisconsin, and then was on a faculty in orthopedics there for 10 years. We didn't have a sports medicine service there, so orthopedics did everything medical and surgical. And then 3 years ago, tomorrow actually, moved to Fort Collins. So I'll be coming up on my anniversary here. And it was kind of good mid-career move and to join the faculty here at CSU. So I do now more orthopedic surgery because we have this separate team who does orthopedic medicine and mobility. And maybe just a little bit of background if those don't understand, those that aren't familiar with that. It's a separate residency training program with a little different focus, but I think very complementary to the surgery residency program. So they go through a same board certification process that I'm familiar with surgery. And I think in services that have both, they kind of work together to manage all orthopedic problems, medical and surgical. So it's really complementary, which is one of the big perks for moving here.
Yeah. Wonderful. And we are going to talk in depth about multimodal pain management. So before we talk about some medicines, though, we're going to start with weight management because we know that weight management is a huge factor when we're looking at mobility and osteoarthritis pain. But we also know that body weight really doesn't tell us the whole story when it comes to osteoarthritis risk. And so I would love it if one or both of you could elaborate on the importance of body condition scoring and talk a little bit about not only how can we incorporate that into our routine practice, but how do we really explain this concept to clients in a way that they understand?
So I think that's one thing that is, I think I always think of as the number one thing if an owner is going to do anything to help manage the dog's mobility is going to be weight management. And I think with management, body condition scoring is complementary. And so I think one of the first things that we do is try to get everybody on board, whether it be students, interns, residents, to grade body condition consistently because it is very subjective. But I think we do know there's several studies that have shown that body condition scoring is probably a more accurate predictor of obesity and health-related risks versus a pure number. The number is great because you can put someone on a scale and it's very precise and you can monitor over time, but it doesn't tell the whole picture, particularly for those that are on the obese side, body conditions over 7. And I think also different breed conformations, heavily muscled dogs are going to weigh more, but their body condition score may not always align correctly. So I think of it as a complementary measure. So every dog that comes in is going to be scored based on the body condition score. We have these posters in all of our rooms. We have them in the waiting rooms. And so I think I try to get owners on board with how we assess body condition scoring, and so they can assess their own dogs and be comfortable with that sort of system, which I think once you show them a couple of pictures of dogs with different body condition scores, I think they can be an active participant in that process. So it helps us from a research clinical trial perspective, but also for general day-to-day patient care. So I think that's kind of been my takeaway. I mean, probably have other things to add.
Yeah, I'd echo everything that Dr. Bleedorn has said and maybe add that we know that there's a wide variation of conformations of dogs out there. And so, just using the body weight, if you wanted to compare a bulldog to, a Labrador retriever, that body weight ratio might not fit. And so adding our body condition scoring in there can really help kind of complete the picture, as well as when we think about some of our geriatric patients where they might have muscle atrophy that's contributing to their weight. Using that body condition score can kind of help us make that assessment of, if this dog's really muscle atrophy but carries, a heavier fat distribution, that dog still is overconditioned, even if he falls in the body weight range that we would expect for that breed. And I would also echo, communicating this to owners and showing them it's not just, oh, my dog has a waist, but this is what the fat coverage over the rib feels like. This is, the fat deposits over the lumbar region, and kind of giving them an idea of what they should be looking for an ideal body condition dog.
Yeah, and I think those visual aids that you both were talking about are great. We also have several signs in exam rooms that go through, and you try to make it accessible for people, and sometimes a little funny, with my chonker cat or something. But also that can also be a place where I find some clients can get a little defensive. And so the other thing too is these discussions can sometimes take time, especially really in-depth nutritional counseling. And, general practitioners, myself included, sometimes don't have a lot of time for that, during our routine day. So have you found any strategies to, streamline some of these weight management discussions, as well as keep our clients engaged without making them feel like defensive or that we're judging them for having an overweight animal?
Yeah, I can kind of start off. And I think what you said right there is like not entering the room as, taking it from a judgmental perspective and not, getting that defensive off the bat. So I kind of broached the subject of saying, one thing I love to talk about with everyone, whether the dog's overconditioned or not, because you can still broach it as, hey, your dog's in an ideal body condition and you're doing amazing. Keep up that work. Or if the dog is overweight, saying, we have a study that actually says that talking to owners about the prolonged lifespan from the period of lifetime study that said dogs kept lean on average lived 2 years longer than dogs that were overweight, had lower rates of cancer, lower rates of osteoarthritis and mobility problems. And just broaching it from I want your dog to live just as long as possible kind of helps take it from I want to do what's best for your dog. And also acknowledging to owners, I don't want to take away treats from your dog. I know that's an important component of the human-animal bond. So let's see if we can find some treat substitutes for that and find things that are maybe a little bit lower calories so that we can still put those things in there and giving them tips and tricks from that perspective. But I do try and highlight the importance of not just mobility, but quality of or prolonged quality of life as a reason to get your dog nice and lean.
mean, one thing that we are sort of spoiled is we have longer appointment times probably than you do in your practice, Dr. Watson. So, but at the same time, there are ways to kind of have the entire team that's involved with the patient care involved. And so I think having all technical staff and other individuals that can help with those conversations are useful. So that way, if you have 20 minutes to really cover a lot of topics, if you have skilled technicians or assistants in your practice, they can also help with some of the tracking as well as some of the conversations, goal settings within reason if they feel comfortable. The other comment to make about the defensiveness and judgmental, I guess I try to just stick to the data, and so you're not judging someone who may be also struggling with the same obesity as their pet. And so, focusing on the quality of life, the longevity, but also the objective information is out there on body condition score and body weight. And so that way you can, use those as data to support your recommendations and hopefully your successes and outcomes.
Yeah, that was a really wonderful study. We actually did a little 2-minute takeaway on it here at Clinician's Briefs. So I want to talk a little bit. You had talked about, Dr. Talsma, about, substituting treats and things like that. Do you have other strategies when we do have owners that are struggling? Because just like you said, weight loss is tough. It's tough for people, It's like, this is not an overnight easy thing that we're going to be able to, have results visible oftentimes very quickly. And so that can cause frustration and setbacks. And when we have these long-term weight management plans, how are we keeping our owners motivated?
Yeah, I think, as far as some tips and tricks of, how you can make some of those everyday changes, I talk to owners about maybe taking small amounts of the kibble away and using those as treats so we're not adding calories, or considering a lower calorie, high protein diet so we can increase that food volume for these dogs. Because one of the most common complaints I get after making diet transitions is my dog is so hungry, it's begging me for food, he's stealing stuff off the counter, things like that. So how can we, make it less of a burden on the dog and the owner at home and less of a dramatic transition? But I do think things like progress photos can be really helpful to say, just like in humans, we expect small changes. This isn't going to be overnight your dog all of a sudden has a bikini body. And so taking those, once every few week photos to say you are making progress, even if that body weight doesn't change, because maybe we're in a rehab program and we're also building muscle mass, and those things are going to influence the body weight. But seeing that change, that waist slim out, maybe the ribs start to become visible at the very, caudal aspect, those can be things that are encouraging for owners to show that they are making progress as they're going, even if it feels slow and frustrating.
And we haven't done this here, but we were doing an outreach visit recently, and one of the clinics had this great wall of they had this had pitched this whatever, it was like a diet month, and then they had their the biggest losers or winners, and then they had photos, and so they had their clients everybody loves taking a photo of your pet, and they had their photos posted there, and so it's just another way to kind of showcase the efforts that are being done, and then share some of the good results. The other maybe comment to make is trying to set the expectations from the outset that it's a slow process. We target 1% body weight per week or 3 to 5 per month, and you need probably at least based on kind of objective measures 6 to 8% reduction to see an improvement in lameness, and so that's if you do the math, that's 2 months before you see any probably difference. So trying to set expectations and realistic timelines. And then the other thing might be is, in addition to the food, is, maybe the dogs aren't losing weight, but they feel better. They're more mobile. They're more active with their owners. And I mean, it's hard to put a score on that, but I mean, to me, that's still a win in that column because maybe they're changing their distribution of muscle and fat composition. That's not reflected on the scale when they walk in your clinic.
Yeah, absolutely. I love that idea of the picture wall. That is just wonderful.
I was taking photos of it to be oh, this is lovely. We should bring this back to CSU.
Yeah. All right, let's move on and talk a little bit about medications. Okay. So we know NSAIDs, they truly remain the first line medication for osteoarthritis pain management in dogs. How are you counseling clients on the risks and benefits when we're using NSAIDs chronically? And I know a lot of general practitioners have differing opinions on monitoring, blood work, time frames. Should we be running in blood work on these animals, especially geriatric animals, before even starting an NSAID? So I know that's a lot. It encompasses a lot of different things, but if you could maybe just outline your kind of broad approach when you're looking at chronic NSAID therapy.
Dr. Talsma, you go. You guys see many.
We do. Yeah, I would say, one of the common things that we see coming in is owners being fearful when I bring up the conversation of chronic NSAID use. And I think that does expand to veterinarians as well. So really important to take a step back and look at, what safety information we have for NSAIDs. And when we look at that, yes, there are, a small population of dogs that do have these idiosyncratic liver reactions. And those are something to educate owners on to monitor for any clinical symptoms after starting an NSAID, loss of appetite, vomiting, diarrhea, lethargy. And if those are noted, to, consult with the prescribing veterinarian. And dogs who are, have pre-existing renal issues and potentially GI issues may not be the best candidates for an NSAID. But beyond that, our generally healthy population that we're seeing is safe to receive an NSAID with that close monitoring. Usually those adverse side effects are going to present within the first 2 weeks. And so I have owners keep me updated for the first 2 weeks how the dog is tolerating the NSAID from a systemic health perspective. Also, how they're doing with their lameness. Is this benefiting the dog? Because if it's not, we might have to go back to the drawing board and say, is there something else going on here that I'm missing and why this dog is not responding? I do, maybe out of an over precaution, do check my renal and hepatic values a month after starting an NSAID, just to make sure we're not seeing any elevations in liver and kidney values. And assuming that all stays the same, dogs that are appropriately dosed on NSAIDs generally can tolerate this well long term. And I do routine blood work monitoring about every 6 months with a full CBC chemistry, maybe a little bit more frequent if you're dealing with a geriatric population, depending on what that dog's blood work looked at, like going into it. But I think one important thing about the dosing is that a lot of these side effects are dose dependent. So ensuring that we're prescribing the appropriate dose of NSAID. And touching back on body weight, I always dose my NSAIDs on lean body weight. So that dog coming in, starting at a BCS 8 out of 9, doesn't just get, 2.2 mg per kg of that body weight of carprofen. You first need to calculate that dog's lean body condition and then give your 2.2 mg per kg from there. So I do find that many dogs do come in on a higher dose of NSAID when they are overweight. And those are the dogs that I tend to see the GI side effects in.
So I guess what I'm hearing is probably having a baseline blood work before you're starting it, particularly if you're going to go for chronic use, and then monitoring every 6 months to maybe a year. But I would agree, it seems like the perceptions on NSAID use are often worse than the reality when you look at the studies that are out there. There was an interesting study out of the UK that looked at the perceptions from veterinarians and owners, and it's way worse than the actual numbers. Not saying the dogs can't have a problem, but I think they get a lot of bad rap, unfortunately. But maybe better to be safe than sorry.
Yeah. There are several other medications out there that people use either in place of NSAIDs or oftentimes along with them. Certainly there's gabapentin, there's tramadol, there's grapiprant, there's new monoclonal antibodies, Tylenol even a lot of people have started using. So are there particular combinations that you reach for? And I think more importantly, are there combinations that you feel are really unsafe and drugs that we should not be using together?
I think probably the most common combination, if we're reaching for a second line therapy beyond NSAID, is probably gabapentin or something in that family. Seems to be safe and well tolerated. some dogs do get overly sedate on the dose of gabapentin. So I think it's worth kind of starting at a range and then working up or down from there. But I'd say that's probably the most frequent combination that we'll reach for, not only for chronic use, but also for more short-term use for post-operative care as well. I'd say the ones that make me a little bit worried, some combination, particularly with the monoclonal antibodies recently. I think we're still learning a lot about those medication class. And so I think that's one area that we've sort of shied away from, combination of NSAIDs with Librela probably being the biggest one that I think there's been the most information available. That being said, it's been used in Europe for much longer than here. And I think the safety studies from Europe are actually probably more encouraging that it's a safe drug, at least as a single agent, not necessarily in combination with an NSAID. So that would probably be the one to your question, as far as I might avoid a combination therapy with that in particular.
Yeah, and I might add, I do use amantadine a fair amount as well for kind of chronic pain management. I do like gabapentin as an option as a second line for the very reasons of it's safe. I do find that my geriatric patients maybe are a little bit more sensitive to it, so I tend to start a little bit lower in the realm of like 5 mg per kg when I'm first starting them on the dose. And then I think the other important thing to note is, we do have limited efficacy studies on gabapentin and its use for pain management. It is nice, especially in that post-operative period, for the opportunity to increase that dose for some mild sedative effects, or maybe if you're arresting a dog because they had an acute flare of their arthritis. But knowing that efficacy is limited in the literature currently, and that the ideal dosing frequency for gabapentin is every 8 hours, and that's not feasible for every owner out there. And so I will also sometimes grab for pregabalin as it's become, more widely available for us at reasonable prices, and that dosing is intended for every 12 hours just based on pharmacokinetic studies. But I do really like amantadine. I think it's pretty easy to dose, pretty limited side effects, and maybe a little bit more literature to support its use.
And then I do want to just touch a little bit more specifically on Bedenvetmab. I know our audience has tons and tons of questions about this medication, especially because the label was recently updated to include some of this post-drug approval experience that we've had in the US and some of the reported adverse effects. As you kind of alluded to, I think they're a little different than the safety studies in Europe, which is interesting to me. Could you just maybe summarize those updates for us and explain, how are you said you're probably not using it along with NSAIDs, at least right now until we have more information, but how are you using this drug in practice?
Yeah, I can maybe start. We see a lot of these kind of like chronic pain management ones where the conversations regarding Bedenvetmab become more common. And I would say the kind of summary of what's been released by the FDA is that there's now this post-approval label change as some adverse effects have been reported. I think namely things that people have been seeing and maybe concerned about are progression of neurologic symptoms such as weakness, ataxia, maybe loss of ability to use the hind limbs. And I think one thing to keep in mind is we are looking at a geriatric population for a lot of these, and it is hard to say, would these things have happened? I do think there's reasonable concern. I do have, some patients as well that I've said, oh, this is a little odd. You never displayed these symptoms before, but I think it just highlights the importance of doing a complete and thorough exam on your patient and reaching a diagnosis of osteoarthritis before considering this medication, because it is labeled for osteoarthritis pain. And we do know that dogs seem to benefit from this medication. So I do think it has a place, but we do spend a lot of time educating owners about potential adverse effects. I personally don't use it in any dog that I have concern for underlying neurologic disease, even if it's a chronic disc that's not displaying overt neurologic symptoms at the time, but maybe I'm getting back pain on my examination. And so careful case selection, educating owners. If I feel this dog can't come off an NSAID, letting them know about the prior human studies with this rapidly progressive osteoarthritis, and that, it hasn't been definitively documented in dogs to be related, but there is that potential concern, and to be aware of that. And so we here have at least just created a little blurb disclosure for owners. That's called our Librella and NSAID disclosure. And we just say, hey, we don't know if this combination is truly safe in the long term. This would be the potential risk. We are advising close monitoring. Right now, your dog is painful, and we do not feel it's fair to take the NSAID away. And often those are dogs where we're looking at their overall quality of life and having those conversations and saying, now we're grabbing for other things to see, how can we improve your overall mobility? Because we reached for a lot of the other tools in the bag already.
Yeah, totally agree. I think that'll be one to watch, because I know there's a couple active studies going on amongst surgery community and those that are trying to collect and learn a bit more about it. But yeah, again, I did listen to a recent abstract that orthopedic meeting 2 weeks ago, and from a gentleman in Europe, and they didn't have any cases in their study of this rapidly progressive arthritis. And so I think there's a little bit of different information that we're hearing from European colleagues. So definitely one that I think will be changing in the near future, and hopefully getting some better guidance when those studies come out.
Thank you for that. Looking for that special clinician or veterinary nurse to fill your job opening? Job seekers from all areas of veterinary medicine can meet their ideal match on the Clinician's Brief Career Center. It's the best place to post your unique job opening and know it will be seen by that special someone. Get started at cliniciansbrief.com/career-center. I'd like to move on to some supplements. One thing, we certainly know that omega-3 fatty acids appear to have the strongest evidence supporting their use in osteoarthritis management. I personally notice quite a variation in the amount of fatty acids in different supplements available, even supplements, that are manufactured and marketed specifically for animals. So how do you determine the appropriate dose? And, do you have any practical considerations when we're trying to find a high quality supplement for our clients?
Yeah, we can maybe touch on a little bit the dosing and finding those supplements. So included in the article that we're going to publish here is actually a dosing calculator for osteoarthritis management. So just by entering patient information, you should be able to get that dose for osteoarthritis, noting that it is quite a bit higher than what we think about for a lot of our other conditions, maybe if you're using it for skin issues and things like that. So there is also other resources online that provide you with that kind of osteoarthritis dosing. And then finding the concentrated products can be really difficult, especially do you find a lot of owners are looking at the front of the bottle for that total omega-3s. But when you actually flip over the back, the things we care about for osteoarthritis are going to be the EPA and the DHA concentration. And even if a capsule has 3,000 milligrams of omega-3s in it, its EPA and DHA concentration can be really low. I tend to stick to veterinary products, just knowing that they're safely formulated for animals and don't contain maybe some of those other ingredients that we might have in our human products, like flavorings or other oils added. And then kind of looking at the back and looking at that EPA and DHA and finding those, products that are a little bit higher in concentration as opposed to what you see on the front of the bottle.
Great. The one study I always reach for is, the NSAID sparing effect of omega-3 fatty acids. And so I think, we see a lot of those that come in on NSAIDs and that haven't tried any supplementations. And so to me, if I can get a similar treatment effect with a supplement that's safer than if we can reduce the dose evidence, to me, that's always a win.
The article does mention also that products containing glucosamine and chondroitin really have not shown consistent efficacy when we're treating osteoarthritis. And this is something that I am seeing echoed, on the human literature as well. So do you have any thoughts about why these supplements remain so popular? And if we have a patient that's already on them or the client really feels like they're helping, is there any harm in leaving our patients on these supplements?
I'm glad you asked that because, it's hard to have this conversation with the pet owner. One thing that I think about with any of the studies on supplements is what is the placebo effect that we see in dogs, whether it be from client or veterinary outcome measures or force play data is, that placebo effect is at least probably 30%, in some studies 40%. And so for a product to be efficacious, it has to beat the placebo by a statistically significant amount. And so I think that's where it's hard with glucosamine and chondroitin and many others where there's a lot of conflicting data. So I think about what is the placebo effect or the caregiver effect with any of these drugs. And so the margin of benefit might be there, but it may be smaller than what we see with the placebo. So hard to know why, I guess in my mind, why there's so much hype on it. Maybe it's because they're very accessible. They're easy. And I think before we learned a lot about omegas and some of the other options we're using now, that was kind of mainstream. That was part of my training. That's what we learned. Every dog was on a product that had glucosamine and chondroitin. And so that was maybe just a function of what information is accessible for people. So as far as safety, I think the safety margin is very good with those medications. And so as long as they're tolerated, it'd be hard to have an owner remove them from your multimodal approach. And so I think it's very reasonable to have them continue those medications, realizing that the benefit that they see may be small. But if that's a safe strategy, then to me, it's one thing to consider doing if they're okay with the way that it's given and the cost associated with the medication. But I don't know, is that part of the ortho medicine team here? That's probably maybe the second tier of supplements.
Yeah, I would say we don't typically go out of our way to recommend glucosamine products because realistically, when we look at it, like supplement costs can add up very quickly. If I'm recommending 3 supplements to a dog, that could easily cost an owner over $100 a month. And so trying to think about where we can best allocate their finances. And so if a dog's already on a glucosamine chondroitin product, I don't tell owners they need to take the dog off, particularly if they feel like they're seeing a benefit from it. We have the discussion about, if it comes down to cost, there are supplements that maybe have more evidence that I would rather them spend their money on. But if they feel their dog is benefiting and it's not a financial restriction for them, those supplements are very safe. So I feel comfortable with them staying on. The only caveat I would give to that is we do have one study that says maybe the combination of glucosamine and UC2 is less effective than giving something like undenatured type 2 collagen alone or glucosamine alone. And again, it's based on one study, but I try and not put dogs on both those supplements at the same time.
No, that's great. And I was actually going to ask a question about some of these other things like the undenatured collagen type 2. I think in addition to finances, it's another thing to give too. And so sometimes that becomes, a barrier for clients. Like when we're giving, we've got a jar full of things that we have to give. And so that tends to be my approach as well. It's like, I don't think it's going to hurt anything, but if it's a pain or he doesn't like it, even though, it's supposed to be beef flavored, it's okay with me if we push that one to the side, maybe for some of these supplements that have more evidence. Are there particular patients that you feel respond better to like the undenatured collagen type 2 or maybe some sort of cannabinoid product?
Yeah, I would say I don't have this undenatured type 2 collagen made the world of a difference on top of everything else I'm doing. But supplements are part of my kind of early conversation in osteoarthritis management. And this is purely just based on my kind of clinical approach. And but starting in younger dogs, if, owners kind of want to jump out of the gate, get things going, I will put them on this undenatured collagen type 2 and their omega-3 fatty acids. The cannabinoids, recent article that I actually published as my residency project looking at the use of CBD for mobility impairments in dogs. And we did actually find improvements in the dogs receiving the CBD compared to these placebo products on our veterinary assessments and our client, owner questionnaires, and approach significance on even force plate. So I do think there is a place for these CBD type products. I think one of the big things to consider is the quality of the product that you're getting, because this is a plant-based product. And so not every product is created equal. And without having FDA regulation as far as what's in those products, I do really educate owners on ensuring that the product that they're using does third-party testing to ensure there's no toxins. There's a couple off-the-shelf studies that looked at toxin concentrations in some of these and their CBD concentrations. And most of the products on the market did not actually contain what they advertised. And so sticking to a few of those select brands, because it is a very costly supplement, I do feel, at least anecdotally, that my older patients that maybe have some neurologic component feel a little bit better on CBD, or those with an osteoarthritis component, and maybe less so those with soft tissue or muscle injuries.
That's a great comment, and that would be true for any of the category supplements that looking for reputable sources, because to ensure that what you see on the label is actually what's in the bottle that you're giving to your dog.
Yeah, there's the National Animal Supplement Council, or the NASC, that will be, some products will put that label on their bottle, but it's also just a free resource to go online. And so whenever a client brings me a product that I'm not familiar with, maybe it's a CBD product they got from a local store, pet store, I'll just do a search through that database to see if they've done third-party testing. Or you can request directly to the company and just say, hey, can I have the product analysis of this? And if they've done that, they should be willing to release those things.
That's a really great tip. I hadn't heard of that. So I'll be sure to look that one up, and we'll link it, for anybody else that wants to look at it in the episode. Let's talk. The final thing we're going to be talking about is rehabilitation. I am super lucky here in Vegas. I do have a rehabilitation center, with an underwater treadmill and a specialist very near me. However, lots of GPs don't have direct access, to a certified rehabilitation specialist or to a facility that will have some of that more advanced equipment. So are there any simple, at-home exercises or mobility strategies that veterinarians can recommend for clients to be doing at home to help support their dog's joint health?
Yeah, I can maybe touch on this since we do a lot of rehab here. I think one thing, just overarching, this is free and this is healthy for your dog and it's healthy for you as a human, but taking your dog for a walk every day. So controlled leashed activity is one of the best things. We tell our clients here, motion is lotion. And so that motion through the joints is lubricating, it's removing waste, and it's bringing nutrients into that joint surface. So taking your dog for a walk a few times a day is one of the best things you can do as a kind of rehabilitative strategy for dogs with osteoarthritis. It's obviously important to be doing what's within the means of your dog without making them look worse, seeming more painful. So it might be a 5-minute walk 3 times a day, but we do have great studies showing the improvement in mobility and lameness in dogs that were regularly exercised, as well as the health benefits for humans when they were taking their dogs for regular leashed walks each day. Apart from that, it kind of becomes dependent on where the dog's at, as far as have they just recently acutely flared things up and they're more painful, or are we looking at just really chronic stuff? But I do really love implementing some hill work where dogs can tolerate it without becoming more sore. So having an owner find a local park, or even if their neighborhood has inclines and declines, and using that to build up some strength as well as talking about having their dog kind of do some backwards walking stuff to strengthen those gluteal and hind end muscles for these dogs with hip dysplasia, cruciate ligament disease, things like that.
Excellent. I mean, I think we all think about it as we age, we lose muscle mass, and the same is true for dogs. And so the strength work becomes even more important, than the intensity of the work. So, a lot of creative ways that people can become creative within their home environment to accomplish that same sort of strength training that they might want to do for themselves. I think the one thing I was going to say, the one thing I try to avoid is this sort of weekend warrior phenomenon, because I think that's where people could get into trouble and maybe contribute to some of these flares. And then just like all of us here in this room here, getting on a consistent kind of daily plan or routine helps everybody. And so they don't end up overdoing it when they have a bit more time in their schedule. So a little bit every day helps.
I love that you use that phrase, because I use that phrase all the time, the weekend warrior. Don't do the weekend warrior where we sit around all week and then we go out and run, like crazy and fetch the ball for an hour on Saturday. So, and the walking backwards thing was a great idea too. Those are the types of things that are super helpful, that once you know about them and you can, give your client some direction, I think that they can make a really big difference. If we get to the point though, where we really need to refer a patient, like are there specific clinical signs or progression indicators that suggest that it's probably time to get this patient to a specialist where they can do some of these more advanced interventions?
I guess a couple of things that come to my mind is if something doesn't make sense, you have a established diagnosis, or maybe you're working off of, clinical exam and you haven't done any imaging to really confirm things because of, whatever motivations financially or within the safety of a patient. If something doesn't add up, you're treating a dog with hip dysplasia and associated hip arthritis, and it's not responding to these approaches that you've tried. To me, those are things that maybe start to look a little deeper, and maybe there's something else lurking there. And so it might need a bit more resources to do more diagnostics. That might be one reason to pursue referral, is maybe for diagnostics that you don't have available in your practice. And the other simple reason might be that just getting another opinion. I lean on my colleagues here. I'm sure you have colleagues in your practice. I mean, it's not a direct referral, but getting another set of eyes on a patient for those ones that don't really add up might be reasons to change a plan or get another opinion on a case. So those are things that I guess I think about referral, or things where, just to help assure that you're going down the right treatment path, or those that aren't responding. The other one comment I'd make, I always learn something new when I work with the rehab team. They have a bit different perspective in their training, especially if you have someone who's trained. We're lucky here, our physical therapist is a human trained doctor or PT. And so they look at mobility in a different light. And sometimes, even if it's a new diagnosis, they have a different sort of training and mindset, and they often catch things that I totally missed. And so I think leaning on them early on rather than late is oftentimes something that I think adds a lot of value in the overall treatment plan.
Yeah, and I think one thing actually that Dr. Bleedorn and I were talking about is the underutilization of having conversations with specialists. So if there are, referral facilities in your area, just reaching out, brainstorming ideas. I would say often, at least here within the departments, we're usually really happy to respond to referring veterinarian kind of questions about these types of things if they feel a little bit stumped, or maybe what their next move is, and we can hopefully help guide them in, next steps of management of care with them, or if it is something that we feel might need referral, and what that might look like for the owner, so they can at least set expectations for owner as far as costs and treatment involvement and things like that.
Yeah, I'm glad you brought that up. That's one thing that I think is totally underutilized. I mean, it doesn't mean that the dog has to come to your practice for another opinion, but sometimes just having that conversation over the phone can help make you feel like you're on the right track, or is it something that prompts referral? Yeah, I think that's something that I think many of us that are here within the university or in a referral practice are very open to doing those consultations to help be a good referral partner.
Yeah, another thing I love about where I practice is our specialists in the area, our local ophthalmologist, our local cardiologist is they'll get on the phone with me, and walk me through something that I'm seeing in front of me. And I really want to stress having that good relationship with your local specialists is invaluable. And it's also, I use it as a way to let clients know, how much I care about their pet and that, I want the best thing. And that's one way that I can sometimes convince them if they are reluctant, due to cost or travel or something like that, to go ahead and pursue that referral. If I've said I've already spoken to this specialist and they really think it's a good idea if you come in, we've done X, Y, and Z, and that's all I can really offer you here. And I think another thing that I try to emphasize is if we're going down the road, we can be utilizing a lot of resources and money that over time are going to be even more than if we had just maybe gone to the specialist in the first place. So those are kind of some of the strategies that I use. But I thank you for sharing some of yours, and I'm glad that we're kind of on the same track there.
Yeah, I'm glad you mentioned that. I think, just having that direct conduit is so nice. Yeah, it sounds like you have a good connection there. So I think that's nice when it works both ways.
Well, that was all of my questions about osteoarthritis management. You guys were excellent. This was a wonderful conversation today. All of our listeners, our regular listeners, know that this is normally the time in the episode where we would play rapid fire, where we would have some just quick would you rather questions. But since there's two of you, we get to play agree or disagree today. So you both were expecting this game. So I had you, before we sat down, I had you grab a piece of paper and just write agree or disagree on each side. And then, yes. And now I am going to just read off a sentence, and then you get to hold up your sign whether or not you agree or disagree. Are you guys ready to play?
Yep.
Are there any ramifications if we're... No.
No, this is just for fun to see if you match your resident. All right, ready? First question, or first statement, I guess. I would rather place a catheter in a dehydrated kitten than in an obese pug. Oh, they both disagree. You would go for the pug, really?
I mean, I think realistically, probably neither one of us have placed a catheter in quite some time. So.
That's why it's hard.
I lean on some very experienced technical staff for that. So maybe abstain would have been a better vote for me. I don't know. What would you have voted, Dr. Watson?
I probably would have gone with the kitten. Yeah, I like those little kitty veins, but the skin and the skin's always tough on the pug. And so... But okay, next question. I would rather be stuck on the phone with a frustrated breeder than a frustrated human nurse. They also both disagree. They would go with the breeder over the nurse. I'm going to leave that one, and we're not going to discuss people's rationales behind that. Okay. Next one, injectable meropitant smells like Band-Aids.
I don't even know if I know what it smells like.
Yeah. I need to go downstairs and smell it, apparently.
I know. I was like, now I'm curious. I'm going to have to ask anesthesia before they give it to one of my patients.
Yeah, you got to go. You got to go smell the injectable meropitant. I thought, you guys would be given lots of that before surgery. Yeah. So...
Interesting. Okay. Is that true? Is that Band-Aids?
I think so. I think some people say gasoline. Yeah, some people say gasoline. Other people say Band-Aids. I think it smells like Band-Aids.
How close do you have to be to smell that?
You just can kind of waft it after
just
you pull it up.
Okay.
Yeah.
All right. I'm going to do this the next time. Yeah.
Okay. I would rather practice without radiography than without ultrasonography.
I would disagree with that. Sorry.
They both disagree. I thought you guys would want your x-rays. So,
Yeah.
All right. Last question.
The bread and butter of orthopedics, right?
Yeah. Radiographs. Yeah.
Yep. Okay. Naming your dog Lucky is a surefire way to guarantee he'll end up with either in an accident or with a horribly rare medical condition. And they both agree. We all agree. Never name your dog Lucky.
Don't do it. Yeah.
I think my favorite are like the humanoid names that we see come into your clinic.
Yeah, those are the greatest. Yeah. All the human dog names. Yeah.
Yep. All right. That was it. That wasn't so bad, right?
No.
That's pretty good.
No.
Wasn't sure what to expect,
All
but that was good.
Yeah.
Well done.
Well, again, thank you both for coming on the show, for sharing your expertise. It was a wonderful conversation, and thank you to our listeners. Everybody be sure to check out the full article in Clinician's Brief because, like we said, there's that bonus dietary calculator, and it's very helpful. It can help you get a nice weight management plan as well as calculate some of the doses of those supplements like we were talking about. So that's great. So we'll see everybody next time.
Awesome. Thanks so much.
Thank you for joining us for today's episode of Clinician's Brief, the podcast. If you enjoyed this episode, you can find us wherever you listen to your favorite podcasts, including a video version on YouTube. While you're there, make sure you subscribe, rate, and review us. You can also listen to or watch our podcast episodes on our website at cliniciansbrief.com/podcasts, or drop us a line at podcasts@vetmedics.com. Clinician's Brief, the podcast, is a VetMedics production, produced by Alexis Ussery and hosted by Dr. Alyssa Watson.